Hello everybody and welcome to our module on treatment of diabetes. In this module we're going to talk about how diabetes is treated, but let me begin by talking about the differences between the ways in which type 1 and type 2 diabetes are treated. So in type 1 diabetes there is a loss of insulin producing cells in the pancreas, so the mainstay of treating type 1 diabetes is with insulin therapy. Children who are type 1 diabetics need lifelong insulin therapy. Type 2 diabetics, on the other hand, especially when they're initially diagnosed, usually have some beta cell function in the pancreas. For this reason, you can administer oral and subcutaneous drugs that either boost the amount of insulin production from the pancreas or increase the sensitivity to insulin. Only later do you need to administer additional insulin as therapy. So in the initial stages, type 2 diabetes is often treated with oral or sub-Q drugs. When the disease becomes advanced and the pancreas begins to fail in its ability to make insulin, that's when insulin is required. And I talk about insulin therapy in another module. In this module, we're going to focus on the oral and subcutaneous drugs. In the diabetes module, I talk about measurement of the serum level of hemoglobin A1C. The level of hemoglobin A1C becomes elevated in patients who have hyperglycemia from diabetes. You can also use the level of hemoglobin A1C in the plasma to monitor response to therapy. If the level is too high, the patient needs additional therapy because they're at increased risk for complications of diabetes. On the other hand, if the level is too low, the patient is at risk for hypoglycemia, and you want to dial back on the amount of therapy you're giving for diabetes. And the goal for most diabetics is usually less than 7%. There are other goals that are used in specific situations. Before we talk about drugs used to treat diabetes, let me mention lifestyle modification. This is usually the first-line therapy in most cases of newly diagnosed type 2 diabetes. And the reason is because weight loss and exercise have been shown in many clinical studies to improve glucose levels. So the first-line therapy in most cases of new type 2 diabetes is to recommend lifestyle modification. Usually a 3 to 6 month trial is initiated unless the A1C is very, very high. If the A1C is markedly high, like 9 or 10%, then lifestyle modifications are not going to work, and you will often start drug therapy initially. But assuming the A1C is not markedly elevated, then lifestyle modifications are usually what you begin with. Unfortunately, lifestyle modifications often don't work, and then there are a number of different oral and subcutaneous injectable anti-diabetic agents that can be used. All of these agents on the slide here can potentially be used to treat type 2 diabetes, and we're going to talk in this module about how each one of them work. We'll begin by talking about the biguanides. Biguanides are chemical structures that have lots of nitrogens and carbons, as shown on the top right side of the screen here. There used to be several biguanides that were used for treatment of diabetes, but now the only one that's used clinically is called metformin. And the reason I'm beginning with metformin is because this is the drug you will most commonly see used on your clinical rotations for treatment of type 2 diabetes. It's an oral therapy. Its exact mechanism of action is unknown. Its primary effect is to lower hepatic glucose production. It inhibits gluconeogenesis and therefore lowers the plasma glucose level. Metformin also lowers the serum levels of free fatty acids. This helps control glucose levels because it decreases the number of substrates available to the liver for gluconeogenesis. This also has a modest beneficial effect on the lipid profile. There will be a decrease in the number of triglycerides in the serum. There's a small decrease in the amount of bad cholesterol or LDL and a small increase in the healthy cholesterol or HDL. Metformin also has some other effects which can lower the serum glucose level in diabetics. It leads to reduced glucose absorption from the GI tract. It has a direct stimulatory effect on glycolysis in tissues. This leads to increased utilization of glucose and therefore lower plasma levels. And in addition, metformin leads to reduced glucagon levels, and as you may know, glucagon raises the level of serum glucose. All of these effects combine to lead to an increased insulin effect in diabetic patients who take metformin. Sometimes this drug is referred to as increasing insulin sensitivity. And in fact, if you measure the insulin levels in patients on metformin, you will see that they fall slightly because insulin is having a greater effect. As I mentioned to you before, metformin is usually first-line therapy in type 2 diabetes. One of the reasons for this is because it is associated with weight loss. As you know, many patients with diabetes are overweight. In addition, many other diabetes therapies, especially insulin, cause weight gain, so the fact that weight loss occurs with metformin makes it a very favorable drug. In addition, it almost never causes hypoglycemia. As we will see, sulfonylureas, another option to metformin, often cause hypoglycemia, and insulin therapy can also cause hypoglycemia. Another advantage is that it does not depend on the beta cells. It can be given to patients with advanced diabetes. Drugs like sulfonylureas, which increase insulin secretion from beta cells, won't work in patients who have advanced diabetes. The most common adverse effect is GI upset. Many patients who take metformin complain of nausea or abdominal pain. Sometimes they notice a metallic taste in their mouth. The feared side effect of metformin is that it can rarely cause a lactic acidosis. The exact mechanism of this is unclear and somewhat controversial. If you do a PubMed search of metformin and lactic acidosis, you'll find lots of papers debating why this adverse event happens. One of the hypothesized mechanisms has to do with the fact that metformin can increase the conversion of glucose to lactate. This is beneficial for lowering glucose levels, but if this happens to too great an extent, it could lead to lactic acidosis. But whatever the mechanism, metformin can lead to lactic acidosis, and it can be a life-threatening side effect. Metformin has an interesting history. It came on the market in the 1950s, and it was pulled from the market in the 1970s over reports of life-threatening and fatal lactic acidosis. In the 1990s, there was a large clinical study that showed it to be highly effective and beneficial for diabetes, and also showed the risk of lactic acidosis to be low, and since that time it's become a very popular diabetes drug. What you need to be aware of regarding lactic acidosis and metformin is that it almost always occurs in association with other conditions, the most important of which is renal insufficiency. Metformin is not given to patients with renal failure over fear of lactic acidosis. Lactic acidosis is also seen in patients who take metformin if they have liver disease or abuse alcohol. It's also been seen in patients with acute heart failure exacerbations, hypoxia, or other serious acute illnesses. So for all of these reasons, as I said before, metformin is not used in patients with chronic kidney disease or a low GFR. It's often held in the hospital when patients are acutely ill. It's also often held during IV contrast tests if patients are going to have a CT scan or a cardiac angiogram and they're going to be administered IV contrast dye, which can cause renal insufficiency. Those patients will often be told to hold their metformin until the test is done. Moving on, our next class of diabetes drugs are the sulfonylureas. At the bottom left side of the screen is the structure of urea, which you know from the urea cycle in biochemistry. On the right side of the screen is the structure of a sulfonylurea drug. You can see that it has a urea molecule in the middle of it attached to a sulfur moiety, hence the name sulfonylurea. These drugs bind to the sulfonylurea receptor in the pancreas. This is a receptor that is associated with ATP-dependent potassium channels in the beta cells. When sulfonylurea drugs bind to this receptor, they close potassium channels in the beta cells. This traps potassium inside the cell and raises the resting potential. This makes it easier for the cell to depolarize, and it results in more depolarization, which leads to an influx of calcium and a release of insulin. This makes the beta cells more sensitive to glucose and amino acids, and it increases the amount of insulin release from the pancreas. Therefore, these drugs are often called insulin secretagogues. Sulfonylureas are very old diabetes drugs. They've been on the market since the 1950s. They are inexpensive, and for this reason, many patients take these. They're oral drugs, and there are several generations of sulfonylureas, and each generation is more potent. Because it's more potent, you can use a lower dosage, and therefore there's less risk of side effects. The first generation drugs are very rarely used anymore. They are drugs like tolbutamide, chlorpropamide, and tolazamide. The second generation drugs are much more commonly used. They are drugs like glyburide and glipizide. And then there's one drug which is sometimes called a third generation drug. Sometimes you'll see it listed as a second generation drug, and it's called glimepiride. The major side effect of these drugs is hypoglycemia, and as I told you before, this is the reason that metformin is preferred over sulfonylureas, because metformin does not cause hypoglycemia. In addition to boosting insulin levels, sulfonylureas also lead to a lowering of the glucagon levels. The exact mechanism is unclear. Glucagon, as you may know, raises plasma glucose levels, so when the glucagon level gets low, the patient is at risk for hypoglycemia. This can occur especially with exercise or skipping meals. When patients exercise, they burn lots of glucose, and therefore if they're taking a sulfonylurea, they can develop symptomatic hypoglycemia. The same thing can happen when patients skip a meal. They have less glucose in their body, and therefore they're at risk for hypoglycemia on these drugs. Another important side effect of these drugs is weight gain. They stimulate insulin release, and you know that insulin promotes weight gain, so it's easy to understand how sulfonylureas could lead to weight gain. Chlorpropamide is a first-generation sulfonylurea. It's not used much anymore, but when this drug was used commonly, it could lead to flushing in patients who consumed alcohol while taking chlorpropamide. The reason for this is because chlorpropamide inhibits the enzyme acetaldehyde dehydrogenase, which is necessary for the metabolism of alcohol. This is the same mechanism by which disulfiram works. Disulfiram is a drug given to prevent alcohol abuse, and I talk more about disulfiram and acetaldehyde dehydrogenase in the biochemistry modules. And then chlorpropamide also had a second unusual side effect, and that was hyponatremia. This is because it increased the activity of ADH. There is another group of diabetes drugs that you can think of as close cousins to the sulfonylureas, and those are the meglitinides. These are drugs like lepaglinide and nataglinide. These are also oral drugs. They have a different chemical structure from sulfonylureas, but a similar mechanism. They also close potassium channels in beta cells, and this leads to increased insulin secretion. They are short-acting, so they're given prior to meals. Their major side effect is hypoglycemia, just like the sulfonylureas. One important difference is that they do not have a sulfur moiety, so they can be used safely in patients who have a sulfa allergy. Moving on, our next class of drugs are the thiazolidinediones, and that's very hard to say, so most people just call them the TZDs. This is their chemical structure shown on the screen here. These drugs all end in glitazone, like pioglitazone and rosiglitazone. They are oral drugs, and they decrease insulin resistance so that whatever insulin function is remaining has more effect on the body. TZDs bind to receptors called PPAR gamma receptors. PPAR stands for peroxisome proliferator activated receptor, and the PPAR gamma receptor is found in the nucleus of cells. The highest levels are in adipose tissue, although you can also find these receptors in muscle, liver, and other tissues, and they modify the expression of a number of genes. The way TZDs work is that they bind to the PPAR gamma receptor, and then the TZD PPAR complex binds to another receptor called RXR. RXR stands for retinoid X receptor. It gets its name because retinoic acid also binds to this receptor. And then the entire complex of the TZD, the PPAR gamma, and the RXR will modify gene expression in the nucleus. Just a side note here, fibrates, which are drugs used in hyperlipidemia, activate a related receptor called PPAR alpha, and this leads to lowering of triglyceride levels. The exact mechanism by which TZDs bind to the PPAR gamma receptor and improve blood sugar levels is not known, and if you do a PubMed search on TZDs, you will find lots of basic science papers trying to understand the mechanism of these drugs. Some of the potential mechanisms that are worth knowing include the GLUT4 receptor. This is a glucose transporter, and its transcription is upregulated in the presence of TZDs bound to the PPAR gamma receptor. Another potential mechanism is a very interesting molecule called adiponectin. This is an adipocyte secretory protein. Remember, I told you that PPAR gamma receptor levels are highest in adipocytes, and adipocytes can secrete adiponectin, and it will increase insulin sensitivity through several mechanisms. So one hypothesis for the way TZDs work is that they lead to more production of adiponectin, and that leads to improved glucose levels. Another mechanism that's been proposed is antagonism of TNF-alpha. TNF-alpha is a well-described molecule that leads to insulin resistance, and TNF-alpha levels may fall in patients taking TZDs. A major side effect of these drugs is weight gain. They may cause proliferation of adipocytes. Remember what I told you before. PPAR gamma receptor levels are highest in adipocytes, so that's where you see a lot of effects from these drugs. In addition, patients on these drugs also can retain fluids. We'll talk about that on the next slide. So for both of these reasons, they tend to gain weight. There's also some risk of hepatotoxicity. An older drug called troglitazone was removed from the market due to reports of liver failure. Edema is an important side effect of these drugs. It occurs in about 5% of patients. It's believed to be due to PPAR gamma effects in the nephron that lead to increased sodium retention. There is a risk of pulmonary edema from all the fluid retention, and for this reason, these drugs are not used in patients with advanced heart failure out of fear of precipitating an acute exacerbation of heart failure. Our next class of diabetes medications are the glucosidase inhibitors. There are 3 drugs in this class: acarbose, miglitol, and voglibose. All of these are competitive inhibitors of enzymes found in the intestine called alpha-glucosidases. Alpha-glucosidases hydrolyze 1,4 bonds between glucose molecules. If you look at the bottom of the screen, this is the chemical structure of maltose. You can see that it's 2 6-carbon sugar molecules linked together, and they are linked in a 1,4 bond. This is the 1 carbon of one molecule. This is the 4 carbon of another. This linkage is called a 1,4 linkage, and that linkage can be hydrolyzed by alpha-glucosidases. The enzyme that hydrolyzes maltose is called maltase, but there are other glucosidase enzymes like sucrase, which hydrolyzes sucrose, also glucoamylase and dextranase. All of these are found in the brush border of intestinal cells, and they all hydrolyze starches, oligosaccharides, and disaccharides, as I just explained. The result of this inhibition will be a slowing in the absorption of glucose. As you know, you can't absorb glucose when it is bound to other molecules. It must be broken off into a glucose molecule. As a result, patients taking glucosidase inhibitors have less absorption of glucose in their upper small intestine. They get more absorption distally in the distal small intestine. These drugs are taken orally just before eating, and as a result of taking a glucosidase inhibitor, patients will have less of a spike in their glucose after meals. That's because the glucose is absorbed more slowly. This means their mean glucose level will be lower, and therefore they will have a lower hemoglobin A1C value. In addition, it means that the pancreas needs to use less insulin in order to metabolize the glucose. Therefore, these drugs are sometimes referred to as insulin sparing. And their main side effect, as you can imagine from their mechanism, is GI upset. If you don't properly absorb carbohydrates, you can develop flatulence and diarrhea just like someone with lactose intolerance. The next class of diabetes drugs are the amylin analogs. There's one important drug in this class. It's called pramlintide. In the module on the endocrine pancreas, I talked about amylin. It's a protein stored in beta cells that is co-secreted with insulin. Its exact physiologic role is not well understood, but when you administer an amylin analog like pramlintide, it has several effects through poorly understood mechanisms. The most important of these is that it suppresses glucagon release. As you know, glucagon raises blood sugar and opposes insulin. So when you suppress glucagon, insulin is able to work more effectively. In addition, amylin analogs like pramlintide have been shown to delay gastric emptying and reduce appetite, and both of these effects also help to lower the blood sugar level. Pramlintide is administered subcutaneously. The patient has to inject this drug, and it's always given together with insulin. It can be used in type 1 as well as type 2. Most of the drugs we're talking about in this module are only for type 2, but pramlintide is special. It is sometimes used in type 1 in patients who have poorly controlled blood sugars, even on insulin. The main side effect is hypoglycemia. Since it's taken with insulin, you can get hypoglycemia just from insulin, and then if you add pramlintide, which suppresses glucagon secretion, you have even greater risk of hypoglycemia. Patients who add this drug to their insulin regimen often need to decrease their insulin dose to prevent hypoglycemia. It's also been shown to cause nausea in a significant number of patients. To understand our next two classes of diabetes drugs, we have to first understand molecules called incretins. Incretins are hormones that increase insulin secretion. One of them is GIP, which I talked about in detail in the GI module on GI hormones. GIP stands for glucose-dependent insulinotropic peptide. It's produced by K cells of the small intestine, and it can increase insulin secretion in response to a meal. Another incretin is called GLP-1. This stands for glucagon-like peptide 1. It's produced by L cells of the small intestines. Just like GIP, it is secreted after meals. It stimulates insulin release similar to GIP. It also blunts glucagon release and slows gastric emptying. And both of these molecules and all of the incretins are responsible for the clinical observation that oral glucose is metabolized faster than IV glucose. When you administer IV glucose to a patient, you do not stimulate incretin release, and therefore it takes longer for that IV glucose to be metabolized. When a patient consumes oral glucose, they stimulate release of GIP and GLP-1. This in turn stimulates insulin secretion, and therefore the oral glucose is metabolized faster. The first class of diabetes drugs related to the incretins are the GLP-1 analogs. There are two important drugs in this class, exenatide and liraglutide. They both mimic the effect of GLP-1 and therefore stimulate insulin release from the pancreas. Exenatide is usually given subcutaneously prior to meals, although there is a new once-weekly version available. Liraglutide is given subcutaneously once daily, and they both carry GI side effects. Patients on these drugs can experience nausea and sometimes vomiting or diarrhea. The second class of diabetes drugs related to the incretins are the DPP-4 inhibitors. There are two important drugs in this class, sitagliptin and linagliptin. DPP-4 stands for dipeptidyl peptidase 4. It's an enzyme expressed on many cells, and it inhibits the release of GIP and GLP-1, the two incretins we just talked about. So when you inhibit the inhibitor, you boost levels of GLP-1, and therefore you have a similar effect to the GLP analogs that we talked about in the last slide. You will boost insulin levels. What's nice about these drugs is that they're oral drugs that can be administered once daily. The side effects are peculiar. There have been reports of infections on patients taking these drugs. The mechanism is not clear, although since DPP-4 is expressed on so many different cell types, it's hypothesized that these drugs may interfere with the immune system's function, but there are reports of increased urinary and respiratory infections among patients taking these drugs. Our last class of anti-diabetic medications are the SGLT2 inhibitors. These are a very recent addition to the U.S. market. They were FDA approved in 2013. There are two drugs in this class, canagliflozin and dapagliflozin. SGLT2 is a glucose transporter expressed in the proximal tubule of the nephron. It reabsorbs about 90% of the filtered load of glucose. So inhibition of this glucose transporter leads to loss of glucose in the urine. As a result, there are lower glucose levels. In addition, there is a mild osmotic diuresis. This is a picture showing the reabsorption of glucose from the urine. SGLT2 reabsorbs glucose along with sodium. There is then another transporter which transports glucose into the tissue interstitium in blood. So if you inhibit SGLT2, then glucose will be left in the urine and it will exit the body with the urine. These drugs are relatively new and they're very expensive, so for that reason you may not see them used very often. They are oral drugs that are taken once daily. One nice thing about these drugs is that they can lead to a mild weight loss. When glucose goes out in the urine, the patient is essentially excreting calories. Those glucose molecules cannot be converted into fat, and therefore it's easy to understand that they're associated with a mild weight loss. In addition, because of the osmotic diuresis, they may improve outcomes among heart failure patients, and there are some data suggesting that heart failure patients with diabetes who take these drugs may have less hospitalizations for acute heart failure. Their adverse effects are easy to understand if you appreciate that they lead to more glucose in the urine. Patients on these drugs report increased incidence of vulvovaginal candidiasis and UTIs, and that's because the glucose is food for Candida fungi or for the bugs that cause UTIs. In addition, these drugs are not recommended with advanced renal disease. They work on the kidneys, and their effects are not well studied in patients who have advanced renal disease. So that concludes our discussion of the different classes of drugs used to treat diabetes. Let me leave you with a couple of helpful tips in answering questions about these drugs on your board exams. They love to ask you about renal failure and metformin. You need to remember that renal failure patients are the group most likely to develop lactic acidosis, and that's why metformin is avoided in renal failure. They also like to ask you which classes of drugs to avoid in advanced heart failure, and you need to remember that you have to avoid the TZDs because they can lead to fluid retention, and you also should avoid metformin because heart failure, in addition to renal failure, is one of the conditions associated with lactic acidosis. And then finally, it's helpful if you can remember that insulin is generally safe with any comorbidity. If they ask you which diabetic drug is most appropriate for a patient with renal failure, heart failure, liver failure, always remember that insulin is generally okay, and if that's one of the choices, it can be helpful to know this. And that concludes our module on treatment of diabetes.